Chapter 10, Venipuncture Procedure. In this chapter, we're going to go over the venipuncture procedure for butterfly and routine vacuator tube method. Blood collection, we're going to consider any special circumstances if the patient's had a mastectomy, diet restrictions, allergies to medication. History of fainting would be some special circumstances. IV placement as well. Assess criteria for recollection and rejection. Prioritize patients and sample tubes and transport and store specimens appropriately. Room temp, refrigerated, frozen. And I'm going to talk about how we assess criteria for recollection and rejection in class. Preparing for the patient encounter, the rationale is to focus mentally on one patient and prepare for his or her specific venipuncture. We're going to prepare and assemble our PPE. Biggest piece of this would be our gloves, phlebotomy supplies, test requisition labels, writing pen, and appropriate patient information. We're going to clean the work areas to promote patient confidence as well. And this is a well-stocked phlebotomy workstation as seen. Preparing for the patient encounter, we're going to be optimistic, retain professional appearance by having clean, well-pressed scrubs, take a deep cleansing breath, and present a positive, professional, neat, and clean appearance. If the patient information is incomplete, we're going to obtain assistance from a supervisor or nurse before collecting the sample. We would never collect the sample and then follow up with care afterwards. Keep the patient calm by offering professional explanations, allowing him or her to ask questions. And I'm going to go back just real quickly. We will go over this in class, but a professional explanation, if they're asking what type of lab work that they are having done, sometimes I inform my patients that it would be best to talk to their doctor or nurse because they know what they're diagnosing them with, so they could give them more information. If the hands are visibly dirty or contaminated, we're going to always use soap and water to clean our hands, but if not visibly soiled, we can use a rubbing alcohol-based hand rub or antimicrobial soap and water. Again, we got to remember that gel in and gel out. We're going to gel in or wash our hands before our patient, and then we're going to gel in or wash our hands after patient contact. Needle stick prevention strategies. Needle sticks occur due to the CDC, the type and design of the needle device used. So this needle device as shown in the image has changed because now we have safety devices built in so we could cap our needle immediately upon taking the needle out of our patient. Recapping the needle. We do never recap a needle. Transferring blood fluids between containers, we now have safety transfer devices that help aid us in transferring blood appropriately to avoid needle stick injury. And improper needle disposal. So you dispose of the needle in the garbage can instead of sharps container. You forget it in the patient's bed. So those are some examples of improper needle disposal. Type and design of needles. 19th century bloodletting, the withdrawal of blood from a patient to cure or prevent illness or disease, is seen in the images below. So this was done to cure a disease, so broken arm, for example. And this has kind of just shown the progress through time to current day. And this is the device we use currently, but it shows you the change in equipment. These are different type of needle holders. As you can see, they've all changed a little bit. And again, I'm going to reiterate the flange on this piece as well. Needle prevention strategies. I will have you read this over in your own time. I'm just going to highlight some key points. Your work will provide a free HPV vaccine to high-risk workers, and phlebotomists are considered that high-risk workers group. What employees can do, we're going to not recap needles. We're going to use appropriate safety devices to transfer samples from one container to the other. And we're going to dispose of our needles appropriately and go through bloodborne pathogen training. The other thing as well, report sharps injuries promptly within less than 24 hours of the needle stick happening. Initial introduction and patient approach. We will go over this in detail in class, so I will just highlight some key features for this. When entering the patient's hospital room, I'm going to knock on the door. Do not pound loudly. The patient is asleep. Turn on the low light at first and speak quietly but professionally. We're going to state the purpose of the interaction. So for phlebotomy, you're going to state your first name and say, I'm a student from the lab. I'm here to draw your blood today. Explain the procedure as you set up. If possible, avoid interrupting if the patient has doctor or chaplain. Come in later. Some physical dispositions we need to be aware of. Patient's diet, alcohol, exercise, and smoking, tendency to faint, latex sensitivity, stress, age, arm preference, and weight are all physical dispositions that are going to kind of change our approach, because how we treat a 5-year-old is different than how we're going to treat a 95-year-old. The other thing too is we got to take into consideration if the patient has anxiety or stress getting their blood drawn, we might need to use a different method to help those patients along. Healthcare worker caring for a patient who feels faint. We will go over this in detail in class. Again, factors that cause pre-analytical variables include, and pre-analytical means prior to testing, age, gender, diet, and exercise, smoking, chewing gum, tobacco, and alcohol. Chewing gum, especially when we're looking at glucose levels. Sometimes medications can alter a patient. IV lines, vascular access devices, pregnancy, menstrual cycle, emotional stress, and psychiatric disorders might very well change our test results. It also could change our approach on how we address these patients and draw from them. These are just some examples of various draw chairs. These type B chairs are really nice in the hospital setting because if we have a patient that faints, we can immediately recline them back. Test requisition. On the test requisition, we need an ordering physician or authorized person. Sometimes it might display special precautions, so if they're a bleeder, faints easily, clinical or billing information when appropriate, and we also might need a diagnosis code or ICD-10 code. The test requisition should contain the patient's ID, name, unique identification registration number, date of birth, and gender, the date and time of collection or status, so is it a time test, is it a stat test or routine, and the test to be performed and the source of the specimen if it is not blood. We're going to check requests prior to venipuncture procedure for discrepancies or duplications in tests ordered, and these are test labels we would get for our patient. And these smaller labels would be the labels that go on our actual specimen. So after grading a conscious patient, we're going to ask the patient to state and spell their full name and their date of birth. This is vital for every phlebotomist. We're going to compare this against our requisition and either an armband of our patient or driver's license in an outpatient setting. Okay. If there are discrepancies, you're going to report it to the responsible supervisor, and discrepancies in patient information must be resolved prior to collecting the specimen. We're going to confirm the information from steps 1 and 2 with another source of reliable, verifiable identification. So a hospital patient's printed identification, registration number on the hospital identification armband and bracelet, or for outpatient we might use a driver's license, a nurse in charge of the patient, or the patient's parent or guardian. For hospitalized patients, the identification should be confirmed with the patient's ID number on the hospital identification band as seen here. This one also includes an image of the patient that's not always present, but it's another thing to verify you have the correct patient. But it cannot be used in place of proper identification by verbal and visually looking at that ID band for the printed number. Basic patient identification. If fasting is required, we're going to ask when was the last time you ate or drank anything. Note the dietary facts. And ask about latex sensitivity, fainting, and arm preference. Most of our facilities now are latex free, but just keep in mind as you go forward with this program that it might be essential to ask initially prior to performing phlebotomy procedures. Procedures do vary slightly depending on the location. In ER, hospital, and clinic settings might have different procedures and policies in place. They have different types of patients, so adults, pediatrics, patient conditions, or consciousness. So we might have some patients in the ER setting that come in unconscious. So how we ID them is going to be drastically different, and the type of ID available at the time, whether it be an armband or driver's license. The Joint Commission use at least 2, unique identification systems. Neither be the patient's room number whenever providing care, treatment, or services. Most use a 3-way match ID system. So it's going to be the verbal from the patient, us checking against the armband or driver's license, and then also having the patient verify the tubes prior to leaving. We do not collect the blood unless ID is confirmed. Seek assistance for clarification. So it uses 2 unique identifiers. All patients except those entering the ER must wear an ID bracelet or armband. Armband must have first and last name and unique ID or hospital number, and always use a 3-way match. So our verbal, our test request, and then our armband. And also most labs have the patient verify the tubes as well. Outpatient ambulatory. If you must call a patient's name from a waiting room, take care not to state any other confidential information. Clinic patients may take longer to identify, and we also need to be aware of patients that are hard of hearing. Photo ID is preferred, and we again use that 3-way match: verbal, test request, driver's license, or other ID. And then we even go even farther to have the patient verify the tubes prior to leaving. Identification for patients who are comatose, semi-conscious, or sleeping. Awaken patient before collecting and verifying patient ID. We need to have consent, which is that nonverbal consent by, they could have nonverbal or what's called implied consent, where they just position their arm out towards you. In this circumstance, that is consent for us to draw. A nurse, relative, or in some cases a friend may identify patients who are unconscious, mentally incompetent, comatose, or cannot speak English, and we compare with the information in the requisition labels to confirm identity. Please be aware different states have different policies when it comes to family members or children identifying patients, so keep that in mind. Identification of infants and young children. Preferable to use the same 3-way match for children when possible. A nurse, parent, or guardian may identify an infant or child by providing the name, address, and identification number and/or birth date. We're going to document the name of the person who confirmed the identification because obviously a child cannot speak, so we need to know who was the one who ID'd that patient, just in case there's any discrepancies. And we have new systems now to where this is a scanning feature and it scans the bracelet and that goes into our system. So that's another way we triple check for children and adults as well. Emergency room patient identification, they are going to get a temporary ID number when they first enter the ER if they are unconscious, and when a permanent ID number is assigned to the patient, we will cross-reference it to that temporary, and then we ensure correct identification, correlation of patient, and test results. So if we cannot ID a patient, they don't have a driver's license, they cannot speak to us, they will get a temporary ID number that identifies them until we establish identification, and then we give them a permanent ID number then. Identity errors are preventable. Most identity errors are due to incorrect requisition, mixed up documentation, failure to follow identification procedures. This can be life-threatening to the patient. Failure to follow identification procedures. If you draw the same patient day after day, we still need to go through that identification process of having the patient state their first, last name, and date of birth. It seems very tedious, but we never know when patients change rooms, and we need to verify that we have the correct patient at all times. Grounds for legal action against the employer or employer or both. And the other thing to keep in mind is grounds for termination from employment. Some places have a 0 tolerance for misidentification. This is an example of the equipment we will be using for a routine venipuncture. And this concludes part 1 of chapter 10. Please view part 2 of chapter 10 to continue with this slide.